this will be important for us to quickly find answers to the MCQs, right? The more you guys get involved in this year's MCQ discussion, the easier it is for us to complete the MCQ discussion as well. Uh, so something regarding this year's, which means 2018 A-level MCQ discussion, is that we are focusing first on how to tackle the MCQ questions as they are, right? And then like from our basic knowledge, we are first of all checking how to tackle the MCQ, and then afterwards gradually we'll go into the relevant theory to the stems which we don't know, right? So that is the way we are doing. So you guys are more than welcome to share your opinions, and also your answers which you have already referred. The preferred two textbooks to refer for MCQ answers is number one, the illustrated textbook of pediatrics, and the other one is the concise textbook of pediatrics. However, usually, even when you can't find answers in those, which is a common thing with pediatrics, we might refer other textbooks, which I'm referring right now. There is a good book called Short Textbook of Pediatrics by Suraj Gupta, right? So I'll share it with you all later on. For now, you guys have to check whether these MCQ answers are there in the illustrated and the concise, and just let me know, and let your peers know as well if you found the answers, and then we can go on with the discussion, right? So with that mentioned, we'll go into the sixth MCQ, which is the one we have discussed today. Which of the following conditions are associated with an abnormal bone age? So something which you need to remember is this. Now, when you talk about a child with short stature, bone age is important in short stature. So I will again recap what short stature is, right? So short stature is when the height is less than minus 2 SD for that population, right? So that is how we discuss and describe short stature. So first thing you need to do is you need to confirm the weight and height of the child, right? So you do it by measuring the weight and the height, and then if it is a child less than 5 years, you have to check the weight for height and plot it in the CHDR chart. Or if the child is more than 5 years old, you need to check the BMI of the child, and then you need to plot it in the CHDR and check whether this child is obese or malnourished or thin or etc. whatever, right? So short stature is there is something problematic with the height. So when you first identify a child with short stature, the first thing you do is you check whether the child is growing along the mid-parental height range. Even when the child is short, it still, if he is growing within the mid-parental height, if he is going to achieve the mid-parental height, then that short stature is not pathological, right? After checking whether the short stature is within the mid-parental height, the next thing which we need to do is that we need to do relevant investigations, right? Relevant investigations to identify the cause for this short stature. So before the investigations, we also do a thorough examination. We look for any features of genetic syndromes, right? And we look for any features of organic illness, right? Organic illness. We look for any features of genetic syndromes, and then we also check for any features of endocrine disease, right? So these are what we do when we are investigating a child for short stature. And we also check if this is a child who is in the pubertal age, which means if the child is more than 10 years, we have to check whether the child is having delayed puberty as well, right? So we have to check the secondary sexual characteristic as well. So this discussion, the identification of delayed puberty and secondary sexual characteristics, and investigating for precocious and delayed puberty is a separate discussion. However, since we are mainly focused on short stature here, after doing a thorough examination and documenting your examination findings, you then do something called upper and lower body ratio, right? Upper and lower body ratio. So you check whether the upper body and lower body ratio is equal or abnormal. So according to that, you can sometimes identify certain genetic disease or organic disease according to the upper body to lower body ratio. And then something else which you also do is you check the born age of the child. So born age of the child is done by requesting the X-ray department. You have to request the X-ray department or the radiology department to do a skeletal survey, right? So they take a X-ray, especially from different areas of the child's body. One of the common areas that is taken is the left wrist joint, and then they look at the growth plates of the wrist and also the carpal bones, and they identify the growth age of the child, right? So there are conditions which lead to short stature with with delayed born age, right? And then there are also conditions which lead to short stature with increased born age, right? So those are two types of short stature causing conditions, right? We'll see now in the MCQ what of the following conditions may be associated with abnormal bone age. The word abnormal bone age means the bone age can be increased or the bone age can be decreased, right? So untreated celiac disease, bone age increased or decreased? Excellent. Bone age is
Decrease.
why? Because the body is in a chronic malnourished state and it is conserving energy to uh, grow again when the celiac disease is treated. So untreated celiac disease leads to decreased bone age. Okay. So this is abnormal bone age. Familial short stature, bone age decreased or increased or normal? Okay.
Normal.
Christy?
Normal.
Okay,
Normal.
yeah, bone age is normal here because the child is growing according to his familial genes. So there is neither a delay no abnormal progression in the growth. So the child is having normal bone age. What is the other condition which can lead to normal bone age with uh, have you heard of this thing called constitutional delay? Does constitutional delay cause increased bone age or decreased bone age or normal bone age? Yeah, this is decreased, huh? Decreased bone age. The bone age is not normal in constitutional delay, right? Do you guys understand the difference between constitutional delay and familial short stature? Disney?
Yeah.
No, not really.
Okay, so
I'm also not.
yeah, so constitutional delay is when someone is delayed as a part of the normal variation. So some people have a delay in their growth as a part of the normal evolutionary process. That is called constitutional delay. However, this familial short stature means that the child is short as part of the familial genetics. The constitutional delay child will have catch-up growth later on, but the familial short stature child will stay short because the child is anyway inherited short according to his familial genetics. So there's a delay here, but the child will grow later to the normal height. This is just a normal variation leading to a abnormal looking delay, right? This is a diagnosis of exclusion. However, familial short stature is also normal. However, there is no delay. This is just the normal growth of the child. It just happened to be that the child is having the genes of his family and his family members are short, so he is also short. It's not because of something pathological. Understood? So the child will not grow later on like in constitutional delay. Understood the difference, Disney?
Yes, yes.
Okay. So being born small for gestational age.
Arunaja, in the constitutional delay, later on the child will catch up the growth, right?
In what?
Constitutional delay?
Yeah, but child will not have catch-up growth in familial short stature.
Okay.
අලේ මොකක්ද කියන්නේ නේද?
Yeah, I was thinking it's false, right?
Yeah, true. Abnormal, being born small for gestational age. Abnormal born age or normal born age? Normal,
Normal, no?
Abnormal, I think it's reduced bone.
Abnormal.
abnormal, reduced. It is reduced
How?
born rate. Because small for gestational age means that the child is having had delayed growth inside the uterus. So when the child comes out, he will have catch-up growth later on. So the bone age is decreased until the child gets good nutrition. However, later on he will have a normal bone age. So up until he gets nutrition, his bone age is decreased.
So it's true, right? The answer?
Yeah, it's true. එච්චරටම හිතන්න ඕනේ නෑ. දැන් being born කියලානේ කියන්නේ. කියන්නේ ඇත්තටම මේකේ එහෙම හිතුවොත් ඕනම MCQ එක true false කියලා ගන්න පුළුවන්. true කියලා හරි false කියලා හරි. අපි අර generally හිතන එක හොඳයි MCQ වලට. අර වචන දීලා තියෙද්දි පොඩ්ඩක් පරිස්සම් වෙන්න ඕනේ. දැන් for an example here මෙන්න මේ most often entirely ඒ වගේ වචන තියෙද්දි පොඩ්ඩක් පරිස්සම් වෙන එක හොඳයි. හැබැයි මේ වගේ එකදී general meaning ගත්තට අවුලක් නෑ මං හිතන්නේ. Isolated growth hormone deficiency, reduced or increased or normal bone age.
Bone age should be
It should be
normal,
reduced,
right?
right?
Reduced. Precocious puberty, reduced or increased bone age.
Increased.
Increase.
So both of these are true, right?
Yeah. Understood, Jarna?
Yeah. Whichever is like abnormal, we have to put it true, no?
Yeah. Whichever is
Okay.
abnormal, we have to put it as true. Right?
Okay.
So we'll see the conditions which lead to short stature that have abnormal bone age, right? So this is a list of conditions with abnormal short stature and normal, list of conditions which lead to short stature. We'll see with increased and decreased bone age. Yeah, so I can't find a list here, but
In the concise, they have given like 4 causes as like in a list, and they are undernutrition,
Mm.
chronic disease,
Mm.
drugs like steroids, and endocrine causes.
Right. Undernutrition, chronic disease, endocrine causes,
and drugs like steroids.
right. Right. Those are conditions which lead to delayed bone age, no?
Yes.
Okay, so good. So these corticosteroids reduce the bone age because they क्लोजर का डिले करना artificial closure delay करना वाले.
So because of that, the bones are weak. Is it so?
Because of that the bones are not growing.
Okay.
Right. That is why you need to check the growth and the height of a child with nephrotic syndrome on corticosteroids.
Okay. Okay.
Arunaja,
Because,
also constitutional short stature comes under this.
yeah, that is also delayed, no?
Yeah.
So corticosteroids they inhibit the growth plate fusion and the growth plate growth. Right? That is what happens. Understood? Which of the following conditions are recognized causes of predominantly direct hyperbilirubinemia in the newborn? Now, I told you last time, direct bilirubinemia, direct hyperbilirubinemia in a conditions කීපයක් තියෙනවා. The first one is polylocal cyst, right? Polylocal cyst. And the second one is neonatal hepatitis syndrome. And I also mentioned that biliary atresia also lead to direct hyperbilirubinemia in children. These are the three definitive conditions, surgical conditions, which lead to neonatal hepatitis syndrome is a medical condition which lead to direct hyperbilirubinemia in newborn, right? So with these three things in mind, we'll go into the answers. Polylocal cyst, so that is a cause for direct hyperbilirubinemia. Systemic gram-negative bacterial sepsis. So we leave it. We'll go to Alagille syndrome. Alagille syndrome is also true. This is a cause for direct hyperbilirubinemia. It causes neonatal hepatitis syndrome. So Alagille syndrome is a congenital metabolic disease, right? And then glucose 6-phosphate dehydrogenase deficiency. You know this causes hemolytic anemia, and this usually causes indirect hyperbilirubinemia, right? So Crigler-Najjar and systemic gram-negative bacterial sepsis is what we need to know. What do you guys know about Crigler-Najjar syndrome? Yeah. So when you talk about Gilbert Gilbert syndrome, Crigler-Najjar syndrome කියන්නේ දෙකක්. එතකොට Gilbert කියන එක normal variation එකක්. හැබැයි Crigler-Najjar syndrome කියන්නේ pathological condition. එතකොට Crigler-Najjar syndrome එක සාමාන්‍යයෙන් වෙන්නේ uptake එක අඩු වෙනවා. right? uptake එක අඩු වෙනවා. Gilbert එකෙත් වෙන්නේ uptake එක අඩු වෙනවා. right? Dubin Johnson and Rotter syndrome කියලා දෙකක් තියෙනවා. ඒකෙදි කරන්නේ secretion එක අඩු වෙනවා. Did you guys understand? I don't think you understood. Wait, I'll explain it later.
No.
So when you take the liver, right? The liver is like this. So they take unconjugated bilirubin inside the liver, and they conjugate it, and they secrete it as conjugated bilirubin. No? So there are conditions which lead to impaired uptake of bilirubin into the liver, and there are conditions which lead to impaired secretion of bilirubin from the liver into the bile. These syndromes which cause abnormality here are Gilbert syndrome and Crigler-Najjar syndrome, right? Gilbert syndrome is a normal variant. It's not taken as a disease. It's seen in normal people also. But Crigler-Najjar syndrome is always abnormal. Right? The liver can't take in the unconjugated bilirubin. And conjugated bilirubin, when it is formed inside the liver, there are certain disorders which cause inability to secrete conjugated bilirubin into the bile, and it becomes stored inside the liver, and that can cause problems within the liver. And those examples are Rotter syndrome, and also one thing is Rotter syndrome, and the other one is Dubin-Johnson syndrome, right? So you need to know the names of these conditions, because these will come into play when we are talking about the different causes for like hepatitis and jaundice in medicine. So Crigler-Najjar syndrome does cause unconjugated bilirubinemia. It doesn't cause direct conjugated bilirubinemia. There now
No, okay.
so there is a list in the neonatal guideline. So I'll share that list now. In the guideline, there is a list of conditions which lead to conjugated hyperbilirubinemia and unconjugated hyperbilirubinemia. Can you see? So these are the conditions which usually lead to hyperbilirubinemia in the child, and we'll see that there was a way that it was differentiated into conjugated and unconjugated. Did any of you find a list where there was given conjugated causes of hyperbilirubinemia and unconjugated causes of hyperbilirubinemia separately? ඉතින් වෙන වෙනම තිබ්බ ලිස්ට් එකක් ඇති concise එකයි. Can someone check and see? Hello?
Yeah, I'm checking the last one.
So these are the conditions which lead to conjugated and unconjugated hyperbilirubinemia. Can you see? So Crigler-Najjar is unconjugated bilirubinemia, hemolysis is unconjugated bilirubinemia, hypothyroidism is unconjugated bilirubinemia, Crigler-Najjar and Gilbert also unconjugated hyperbilirubinemia. Sepsis is conjugated bilirubinemia, right? Biliary atresia, neonatal hepatitis syndrome, polydocal cyst are all conjugated, right? Dubin-Johnson and Rotta are also conjugated. There are the
Arunaja, by the way, this Dubin-Johnson Rotter syndrome, they affect the secretion of conjugated hyperbilirubin, like conjugated bilirubin, right?
Yeah, they affect the secretion of conjugated bile in bilirubin into the bile.
So how is that going to cause an increase in like conjugate bilirubin levels?
Because when you can't secrete the conjugated bilirubin into the bile, this gets secreted into the bloodstream.
Okay.
Because it has to go somewhere, no, it just
okay.
disappear, right?
Yeah.
Understood?
Yes.
So systemic gram-negative sepsis leads to conjugated bilirubinemia, right? So direct hyperbilirubinemia is true. Ale තේරුණාද දේශබන්දු? Which of the following conditions are typically present with significantly elevated serum ferritin levels? Serum ferritin is an acute phase protein. It increases when there is a systemic inflammatory response, right? And this can be due to an infection, or this can also be due to autoimmune or kind of inflammatory reason, right? So we will check what conditions lead to increased serum ferritin levels. Multi-system inflammatory syndrome in children. Now there is a problem here, significantly elevated, right? That is a keyword which is included in the MCQ, right? MISC or multi-inflammatory systemic syndrome is something like what do you call this? It's a like a SLE condition, but not like SLE, but you get kind of this systemic inflammation in one or more organs, right? That is due to autoimmune condition. there you get lot of inflammatory response, cytokines and different inflammatory mediators. So the serum ferritin levels do increase in multisystem inflammatory syndrome, right? Chronic hookworm infection. What happens to the hemoglobin level in hookworm infection? It reduces. So because of that, the serum ferritin levels, what does it happen? What happens here? It reduces.
Reduce.
Reduces.
It cannot increase. No, this is false. Active systemic onset juvenile idiopathic arthritis. This is true. When there is active disease, serum ferritin levels are increased because this is a severe autoimmune inflammatory condition. Hereditary hemochromatosis. In hereditary hemochromatosis, there is increased iron deposition in the tissue. So serum ferritin is the molecule which stores iron inside tissues. So serum ferritin levels are increased. Acute severe malnutrition. Acute severe malnutrition, there is likely to be anemia and serum ferritin levels are likely to be decreased. Right? Not very hard, neither. If you kind of now you identify the first two MCQs are a bit difficult. However, later on when you go into the MCQs, they are not that difficult. You can definitely get.
It's confusing
Huh?
because of the wording. Because of the wording, it is confusing. Even if we know, we might put like instead of
Anything
true false.
Yeah, anything is confusing in Dharma. You just have to be patient.
Mm,
Understood?
okay. Mm.
Yeah, you just have to be patient, I guess. In the exam, one of the major things you need to keep in mind is you need to have the patience, because if you don't have the patience and you kind of get stressed and overthink stuff, sometimes even the things which you are bound to get correct will be difficult to understand. Understood? Everyone understand that. So don't get stressed. Just take your time. There is enough time. I think you get 2 hours for the MCQ, ne?
Yeah.
Yeah, 2 hours for the
Yeah.
MCQ. So don't get stressed or anything like that. Just focus on what you need to do and do it. And you guys will do well also, right? We have discussed all the MCQs in the past, ne? Right? So there is no way you guys can do bad, right? So we'll go to the next one. Which of the following statements concerning childhood obesity are correct? So something you need to remember is that childhood obesity, right? Childhood obesity is taken as weight to height more than plus 2 SD in children less than 5 years, and BMI more than plus 3 SD in children older than 5 years. Right? This is how you identify childhood obesity. Right? So we'll go and identify what they have asked. Which of the following statements concerning childhood obesity are correct? It is commonly defined as body mass index greater than 90th centile for age and sex. This is true. This is the universal definition, right? An increased height velocity is a typical finding in simple obesity. In simple obesity, there is normal height velocity. There is no increased height velocity. So we'll just keep it for the time being and go to the next one. Cholelithiasis is a recognized long-term complication. True or false? In obesity, is cholelithiasis a long-term complication? Cholelithiasis means gallstones.
True, Naga.
True. Why? What is the reason behind it being true? When the child is obese, there is increased cholesterol synthesis in the body because of the increased cholesterol that is absorbed from the food, right? And all this additional cholesterol is converted into bile salts, and these bile salts get secreted into the bile and they will cause bile salt stones, right? Benign intracranial hypertension is a rare but recognized complication. True or false? This is true. In benign intracranial hypertension, obesity is one of the complications. What is the treatment for benign intracranial hypertension? Jarna, can you remember? Yes, acetazolamide.
Acetazolamide.
Remember, we did
Yeah.
in the medicine MCQ 2017, last MCQ. There is an increased risk of developing slip upper femoral epiphysis. True or false?
True.
Yeah,
True.
true.
What is this also known as? Is there a name for this condition? What is Perthes disease? Hello, hello.
No idea.
No idea.
Perthes disease is idiopathic avascular necrosis of femoral head. Right? This is also common in children who are obese. Right? Can you guys go into the chapter regarding obesity in the concise textbook of pediatrics? That is a question that they will repeatedly ask in the next exams also. So we'll just confirm and go through all the answers this time and clear it up. Can you go through that section in the concise textbook and let me know what are the complications of obesity that they have mentioned in concise? Can Deshabandhu do that for me?
I have the
No.
list with me, Arunaja.
Okay, then you can also do it.
Shall I say it?
Yeah, say
Yeah,
for
okay.
everyone to know.
So there is medical complications, social emotional consequences, and
Can you
academic.
put a photo of that in the group also, reasoning?
I'm sorry.
Can you put a photo of that
Yes,
page
yes.
or a
Okay,
screenshot?
Can you
That
check the
okay.
page number? Is it?
30.
Okay.
Also, another in the same page regarding stem number 2, it
hmm,
says bone age is advanced in nutritional obesity.
right. Does it say about growth velocity?
Uh, Wait, 1 second.
Bone age is advanced, but is there a sentence on growth velocity?
Height velocity and bone age advanced in nutritional obesity.
Right, both are advanced it seems. Eh?
Yeah.
Right. So we got the answer to that. So increased height velocity is a typical finding in simple obesity is true. Right? And also we now found that bone age is also increased in nutritional obesity. Right. Are there any other medical or surgical complications mentioned?
No, this is it. This is the only list we found.
That is the only thing that is mentioned, is it?
Yes.
Yeah. Any other? Any other complications mentioned in a child with obesity?
I mean, I have sent the picture to the group regarding.
Social, economic, and academic. That is missed.
Sorry, Jahan, I didn't
Hello.
get that.
In the list, they have mentioned medical, social, emotional, and academic consequences.
Mm-hmm.
So, yeah, the one which Rizmi sent.
Simple obesity කියන්නේ මචං මේ nutritional obesity කියන එකට තමයි. Right, so there are a lot of complications, right? So medical complications are type 2 diabetes, dyslipidemia, hypertension, fatty liver disease, fatty steatohepatitis, obstructive sleep apnea, heart disease, polylithiasis, menstrual disorders, sleep upper femoral epiphyseal, fungal disease of skin, asthma. Right? Benign intracranial hypertension is also a rare complication. Right? So you guys understood all the complications now? Okay, so we'll go into the next one. ඒක ෂේප්ද අලේ මොකක්ද ඔය ඇහුවේ වෙන මොන හරි අහන්න තියනවද? Right. Which of the following statements regarding measles infection are accurate? They're asking about measles, right? Characteristic rash is papular and vesicular. True or false? Hello.
False.
What is the characteristic shape of the rash?
Maculopapular.
Maculopapular, eh?
Macular. Excellent. Infection confers long-term protective immunity to the individual. True or false?
True.
No.
True. Yeah, unless the patient gets immunocompromised state, this immunity is usually long-lasting, right? What about varicella zoster virus infection?
They can get.
Vesicular either.
In the future, again.
That is
Vesicular.
Yeah, they can get again.
That is vesicular rash, but what about the
Vesicular.
They
immunity?
don't develop immunity, no? They can get again.
Shingles they can get, right?
Yeah.
They usually don't get shingles again, but sometimes when the immunity reduces, they can get the infection, right? Understood?
So
Yeah.
we can also say that varicella zoster causes like confers long-term protective immunity.
That you have to be careful. I would suggest you not to answer that and go to the next step.
Oh, okay.
Okay. Typical incubation period is approximately 5 to 7 days. True or false? This is true. The virus is primarily transmitted via airborne droplets from respiratory secretions. True or false? What is the other way of transmission?
True. Right?
There is another way of transmission. What is that? Ale?
Mashallah, maybe.
Contact is
Yeah, direct contact.
direct contact.
දේශබන්ධ මොකක් කරේ යවුනේ නේද? දේශබන්ධ මොකක් කරේ යවුනේ නේද?
Arunaja,
Yeah.
the incubation period in concise it says it's 8 to 12 days, I think, for measles.
Sure.
Let me check once again. It's just a note I took down. Let me confirm.
Right. අලේ sorry දේශබන්ධ එහෙම තිබ්බේ.
Oh, page number 84.
Right. එහෙනම් 8 to 12 නේ.
8 to 12 yearly.
Yeah, concise.
Page number 84.
This was right. So shall we go into the next one then? Severe infection is often associated with precipitation of vitamin A deficiency. True or false? This is true. Usually after measles, you need to give the children vitamin A supplementation, right? The reason is these children are usually deficient in vitamin A after measles because measles destroys the epithelial lining and it disrupts epithelial reproliferation, right? So unless you give vitamin A supplementation, there won't be reepithelialization. And these children are also very high risk for getting infections of the immunocompromised state, right? Because these children after measles, they get a state of immunocompromise which lasts for like one year, right? So this is a common incident with measles. So why do we give measles vaccine to patients? What is the importance of giving measles vaccine?
To develop immunity against it.
Yeah, of course, because it gives immunity to the measles virus. But why do we need to give immunity to the measles virus? What is the problem with measles? Measles can lead to severe complications, like it can lead to severe infections of immunocompromised, and after the child is infected with measles, that is one complication of measles infection, and it can also cause something called subsclerosing pan encephalitis, right? So subacute sclerosing pan encephalitis, which leads to destruction of CNS tissue in children. Then afterwards, after measles infection, the child will get meningitis and encephalitis, and the child will be neurologically impaired afterwards. So it is to prevent that major complication, we are giving a measles vaccine. Understood? Arunaja.
Yes.
So there is a difference between measles and varicella. Those are the two of the commonest rashes which are caused in children by a virus. So you need to know the differences between measles and varicella. So I just included a small document which has the basic differences between varicella and measles, right? So just read those two differences. It is mainly regarding the differences between the rashes that they get, right? Arunaja.
Yeah.
Okay. So we go into the next one. Which of the following medications are recognized as having potential nephrotoxicity even when administered within the standard therapeutic dose ranges? Potential nephrotoxicity even when administered in the standard therapeutic dose ranges. Paracetamol, acetaminophen. Does it have nephrotoxicity in the normal range?
No.
No. Does it have nephrotoxicity in the toxic range?
Not sure. I think it causes hepatotoxicity.
Yeah, it causes hepatotoxicity and nephrotoxicity both when it is in the toxic range. Understood?
Yeah. Okay.
Yes, sir. What? Paracetamol, Macha. Right? Acyclovir, does it cause nephrotoxicity in the standard therapeutic dose range? Yes. It causes crystal nephropathy sometimes in patients who are dehydrated. So you have to keep the patient well hydrated when giving acyclovir. Understood?
Yes.
Vancomycin,
Yeah.
does it cause nephrotoxicity in the normal ranges? Yes. It is a glycopeptide antibiotic, and it causes nephrotoxicity. Gentamicin, does it cause nephrotoxicity in the standard therapeutic dose range?
Yes.
Yes.
Yeah, no?
What is the other complication that can be caused by gentamicin in the normal therapeutic range?
Hepatotoxicity?
Huh?
Blind thing?
Huh?
Oh. No, 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 no. Sorry, sorry. I got it.
Ototoxicity and vestibular toxicity. Blindness is not something caused by gentamicin. Huh? Theophylline. Does theophylline cause nephrotoxicity when used within the standard therapeutic dose range?
No.
It doesn't. As I
No.
know it doesn't, we'll just check.
Cardiac and CNS toxicity.
Hmm.
Macha.
Another, so vestibular toxicity means they're likely to get vertigo and all those kind of problems, balance problems.
Yeah, yeah.
Okay.
So according to the ChatGPT, it does not cause any nephrotoxicity in the normal range. Right? What it causes is QT prolongation and also ventricular tachycardia and ventricular fibrillation when used for a long duration in the toxic range, in the toxic dose range. Understood? So we will go into the next one. Which of the following statements about childhood and adolescent lymphoma are correct? What is lymphoma? Hello. Ali? Yes, excellent. මේ ඔය වගේ ඒවා අහනවා හොඳ ලෝන් කේස් එකේ ඒතකොට ටික කෙලින්ම කියපන්. බය වෙන්න එපා. Right? Malignancy of the lymphatic tissue. So what are the types of lymphoma that you guys know?
Hodgkin, non-Hodgkin.
Hodgkin, acute, myeloid leukemia.
මොකද ජහර්ණ කිව්වේ?
Acute and chronic myeloid leukemia.
No. That is
Oh, sorry.
leukemia.
Lymphoma, no?
It's only Hodgkin's and non-Hodgkin's, right?
Hodgkin, no. Hodgkin and no.
Yeah, excellent. So Hodgkin and non-Hodgkin are the two types. If you say acute and chronic, that is wrong. Huh? There another. Right, now you guys are going to tell me the difference between these two. Can you tell? This thing, one difference between Hodgkin and non-Hodgkin lymphoma?
Hodgkin lymphoma has B symptoms, classic B symptoms.
Okay. What about non-Hodgkin?
Non-Hodgkin's, these are not present.
Right, usually not present, but they can be present.
Yeah, usually not present.
Okay, Ale? Yeah, good. That is called Reed-Sternberg cell, seen in Hodgkin lymphoma. Here, what do you see? Ale, in non-Hodgkin lymphoma? Okay, no Reed-Sternberg cell, but depending on the histological type, you can see different types of non-Hodgkin cells, right? Different cell types are there for different types of non-Hodgkin lymphoma. Jaharna, any other differences between these two?
Hodgkin, it originates from B cell, almost always. And then non-Hodgkin, B cell, T cell. Yeah.
You sure?
Not sure. As per my memory, Hodgkin is from B cell. Non-Hodgkin, it is also from B cell, but T cell is also there.
Okay. Any other differences? You are true. You are correct. Huh? B cell origin, and this is B cell plus other origin.
Lymph node, the straight,
Congruous lymph node group involvement.
In what?
contiguous spread and
Hodgkin congruous lymph node group involvement එක. අරකේ non-congruous එක නේද?
Non-Hodgkin's එකේ මොකක්ද දෙන්නේ?
Haphazard.
non එක නේද?
Non-contiguous.
Non-contiguous.
What about the age groups?
පොඩි අය non-Hodgkin නේ.
You sure?
Let me check.
Yes. Marandipa.
no.
You get Hodgkin's lymphoma in adolescents, commonly, and young adults. You get non-Hodgkin's in very small children. Understood?
Yeah.
Any other differences? Guys, any other differences?
I think for treatment for Hodgkin's, radiotherapy alone is enough, but for non-Hodgkin's, it depends on the type of disease.
So for Hodgkin, you are saying radiotherapy is only enough?
Chemoradiotherapy, not very sure.
Right. We'll just check that, right? So Hodgkin's disease peak incidence is in 15 years of age, right? So good, these are the differences we identified. They will ask these differences in the pediatric long case and also in the short case. Sometimes if the patient is found to have a lymphoma in the hepatosplenomegaly abdomen short case, or if you identify lymph nodes, right? If you identify lymph nodes in the abdomen short case, they will ask what is the DD, and then if you say lymphoma, what sort of lymphoma do you think is seen in this child commonly? So depending on the child's age, you have to identify whether it is likely Hodgkin's or non-Hodgkin's. If it's an older child, it is likely non-Hodgkin's. If it is it's a Hodgkin's. If it is a young child, like 2 to 3, 5 years old child, it is usually non-Hodgkin's. Understood? So I'm just looking at the differences between Hodgkin's and non-Hodgkin's. Yeah, so usually it is chemoradiotherapy treatment, right? For non-Hodgkin's lymphoma, what is the treatment usually?
I remember you said it depends on the histological type.
Yeah, ideally it depends on the histological type, but usually I think it is chemotherapy.
Okay.
I have to check that. Okay? I'm checking it now. Just give me a second.
Concise එකේ තියෙනවා මේ කීමෝതെරපි කියලා බං.
Chemotherapy.
Page number 428. ඒකේ මේ වගුවක් තියෙනවා ඒකේ කීමෝതെරපි කියලා දීලා තියෙනවා.
Hodgkin's the non-Hodgkin's the?
Non-Hodgkin's. Hodgkin's වල chemotherapy and radiotherapy.
Right. ඒ වගුව දාන්න group එකට.
මාෂා මම මේ ටැබ් එකෙන් ඉන්නේ මං ගියොත් මේ ආපහු මේ
Alright. එහෙනම් SS එකක් ගහ ගන්නවා.
හරි.
Treatment is a combination of, yeah. So even for non-Hodgkin's, it is more aggressive chemotherapy. Right. So remember, I mentioned earlier that these lymphomas can convert into leukemia, or leukemia can be converted into lymphoma also, right? So that you need to keep in mind. What are the lymphoma types you can identify? Now, Jahatna, your time. What are the leukemias that you know? Hello.
Acute, acute myeloid leukemia.
We'll first talk about the 2 cell lines in the blood circulation. What are the 2 cell lines? In the bone marrow, what are the 2 cell lines which causes leukemia usually? Hello.
Myeloid.
Myeloid lineage and lymphoid lineage. Okay. So, what are the common myeloid leukemias that you know, and what are the common lymphoid leukemias that you know? Jarna?
Yeah.
Yeah, what are the myeloid leukemias you know?
Acute myeloid leukemia and chronic.
Acute. So AML.
Chronic. And
chronic.
CML.
CML. Right. Okay. What is the? How do you say it is CML or AML?
Based on the timing.
So why do you say sometimes it is chronic? What is the reason? What is the reason that you name some leukemias as chronic leukemias?
Don't know.
Right. So chronic leukemia means it is comprising of old mature cells.
Okay.
Right. Myeloid leukemia means that it is composed of immature myeloid cells.
Mm.
And lymphoid leukemias, what sort of classification do we have? Ale? So, right. So, why do you say chronic lymphoid leukemia for CLL, Ale? Yeah, because you have mature cells here, and then immature cells are seen in acute lymphoblastic leukemia. So, what is more severe, ALL or CLL? Why? Right. Jaharna, what is more severe, CML or AML?
CML or AML?
Yeah. What is more severe?
AML.
Yeah. Why?
Because they have immature cells, so it will mature
Excellent.
and
So when the cells are immature, the cells are not differentiated at all, no? Right?
yeah.
Just imagine that a medical faculty is producing doctors, right? So just imagine all the old consultants disappear from the country, right? Will that be worse? So will increase in the consultant number cause a problem to the patients? In the patient's aspect, what do you think?
Wait, I didn't understand.
Just
Increase in
imagine the
consultant
medical
number.
faculty. Yeah,
Oh,
there are doctors in a country. There are
okay.
old, mature doctors, and there are immature new graduates like you and me.
Mm,
Right? Just
okay.
imagine, for instance, the new graduate numbers increase so much, and the old graduate disappear from the country. And in one country, the old graduates are the ones who are increasing in size, and the new graduates disappear. In which country
Okay.
will be more the patients more benefited? In the country with the new graduate number or the old graduate number?
Old graduate.
Yeah, why? Because those people are more knowledgeable, no?
Yeah.
Yeah, like that. The even the cells, when they are more mature, they cause less problems to the body. However, when there are lots of immature cells, it cause more problems. So AML and ALL are more severe. Understood?
Yeah.
So ALL, there is a further classification. ALL can be B cell precursors, or ALL can also be due to T cell precursors. Right? Understood?
Yep.
And I am now checking about yeah, CML and ALL. Mm, right. So these are the types that you need to know, and if you know up to now, this is enough. Right? This is the same kind of classification of leukemia in adults. Right? So you need to know this for both medicine and PED. So with that in mind, we'll go to the question today. Lymphadenopathy is classified as a B symptom. True or false?
False.
What are the B symptoms?
Fever,
Okay.
night
Weight
sweat,
loss.
weight loss.
Okay. Fever.
Fever, weight loss, and night sweats.
Night shift.
Facial swelling, particularly from superior vena cava obstruction, can be a presenting clinical feature. True or false? True. This is called superior vena cava syndrome, SVC syndrome. Right? This is common with mediastinal lymphadenopathy. Understood? So if there is Hodgkin lymphoma or non-Hodgkin's lymphoma involve the mediastinal lymph node group, if it increases in size, they can cause obstruction of the superior vena cava, and that can cause superior vena cava syndrome with uh, swelling of the face. Understood? Hodgkin's lymphoma is a good overall prognosis. True or false? True. Non-Hodgkin's lymphoma is statistically more common in adolescents than Hodgkin's lymphoma. True or false?
False.
False.
The presence of Reed-Sternberg cell is a diagnostic hallmark of non-Hodgkin lymphoma. True or false?
False.
Easy neither, relatively.
Yeah.
So we go into the next one. Which of the following statements are true concerning infantile pyloric stenosis? It shows a strong predilection for firstborn male child. Strong predilection means it is commonly seen in firstborn male children. True or false? Pyloric stenosis. True or false in firstborn male children? Ale? True. Make again a surgery short case surgery SCQ. Right? So just make it katapadam make it in katapadam keep you. Palpable epigastric mass is typically seen after a test feed. True or false? True. Today,
True.
go and read about this infantile hypertrophic pyloric stenosis. You feel this olive-shaped mass in the right hypochondria of the abdomen. Right? Classically causes hyperchloremic metabolic acidosis. True or false? Reasoning? You have only P.
Not sure if it's
False. Why?
hypo.
These patients, how do these patients with infantile hypertrophic pyloric stenosis present?
Projectile
Huh?
vomiting.
What sort of vomiting?
Projectile vomiting.
Okay, so if gastric content is vomited out, does it lead to metabolic acidosis or alkalosis?
It leads to metabolic alkalosis.
Why?
Because the stomach's contains
Gastric acid.
acid, so if most of that is vomited out, it leads to reduced acidity in blood in the body, so it causes alkalosis.
Okay, so is stomach fluid rich in potassium?
That's what I'm not sure about.
Yeah, that is true. It is rich in potassium. All intestinal secretions are rich in potassium. So it will it cause hypokalemia or hyperkalemia?
Hypokalemia.
Okay, is stomach fluid rich in chlorine?
Yes, it is.
Why?
Because HCl.
Yeah, so it will cause hypokalemic, hypochloremic, metabolic alkalosis. Understood?
Yes.
Significant weight loss early is a prominent and presenting feature. True or false? False. Usually these children will not have any weight loss. They will have vomiting only. Definitive management typically necessitates immediate urgent surgical intervention. True or false? False. This is not a surgical emergency. Okay? This is not a surgical emergency. This is a elective surgery. What do they do? What is the surgery which they do for hypertrophic pyloric stenosis? They do sphincterectomy. They cut the sphincter there. Understood? We'll do one more in 6 and stop. Huh? Did you guys understand? So today go and read about
Yeah.
hypertrophic pyloric stenosis in the concise. That is more than enough for surgery and for medicine, for PAED, right?
Mm.
So 14th one, a 10-year-old presenting with multiple joint pains for 3 months. Which of the following features are more suggestive of JIA than SLE? Right? Intermittent fever. True or false? In JIA and SLE, both you can get intermittent fever. What sort of fever do you get in JIA? PUO long case, pediatrics, Visni. What sort of fever do you get in JIA?
Pyroxyphalange?
That is, of course, PUO. What sort of pattern of fever do you get in JIA?
Remittent.
Quotidian fever. Understood? Every 4 days you get fever.
Yeah.
Understood?
Yes.
Prominent early morning stiffness seen in either JIA or SLE or both. Ale?
They.
Both are inflammatory arthritis.
Both.
Yeah. Presence of high titer of rheumatoid factor. More suggestive JIA කියලා නේ අහන්නේ. True or false? Rheumatoid factor high levels. JIA or SLE? Not in either, no?
Mm-hmm.
It is false. Normocytic anemia. More suggestive of JIA than SLE? True or false? False.
False.
They will also have microcytic hypochromic anemia due to anemia of chronic disease. Understood?
Mm.
Increased ESR levels. Common in JIA than SLE or seen in both?
Both.
Both. Ne?
Good. So we did 14 MCQs. Do you want to do one more? We'll do one more. Okay. Which of the following conditions are primarily characterized by monogenic inheritance? Earlier we discussed about polygenic inheritance for myelomeningocele. Remember? So now we are talking about monogenic inheritance. Monogenic inheritance means only one gene is involved. One gene is involved and one gene is inherited. Understood? So we'll go into the conditions. Down syndrome. Monogenic or polygenic?
Monogenic, right? It's just
21 එක trisomy එක.
21 only, right?
Cannot be taken, no? Klinefelter. Monogenic or polygenic? Chromosome. False.
Chromosome.
Noonan syndrome. Monogenic or polygenic? Monogenic. Which chromosome? Noonan syndrome? Hello. Chromosome 15, no? Remember. Hemophilia A, monogenic or polygenic?
Mono.
Monogenic නේද?
Marfan syndrome, monogenic or polygenic? Poly. I discussed this Marfan syndrome in that pediatric case class. Good. Disney, how is Marfan syndrome inherited? That day I told.
syndrome.
Did I tell or not tell?
You did tell.
Yeah, this is inherited in
Autosomal.
What are the features of Noonan syndrome? What sort of cardiac condition do you get in Noonan syndrome? Hello. You guys are so quiet. What sort of cardiac condition do you get in Noonan syndrome? No?
Pulmonary stenosis.
You get pulmonary
Pulmonary-
මතක
pulmonary what? Jana?
Pulmonary stenosis.
Pulmonary stenosis. Good. So those are the things which are seen, right? Okay, so did you guys understand today's session?
Ordinary, one small doubt.
Yeah.
What does monogenic and polygenic inheritance actually mean?
It means that only one gene is problematic which causes the disease versus many genes problematic which cause the disease. In Down syndrome, there are many genes which are reduplicated because of the trisomy. Right? In Klinefelter, there are many genes which are lost because of the loss of the X chromosome. Sorry, Y chromosome. Sorry, Y name, because of the increased inheritance of the X chromosome. However, in Noonan, hemophilia A, all these things, only one gene is inherited. One gene is problematic. Understood?
No, I still didn't get it.
Yeah, even I didn't get it now.
Yeah. Now, how many genes are there in one chromosome?
One chromosome, 23.
How many genes are in one chromosome? There are 23 chromosomes. But how many genes are in one chromosome? Alex?
ටෝටල් තියෙනවද
Uncountable.
බිලියන්ස්
Wait, today you guys go and see what is a chromosome and what is a gene. I think you guys are having a problem there. Understood?
Mm-hmm.
There are many genes, thousands and thousands of genes inside a chromosome. So, when there is a chromosomal problem, many genes will be involved. So, that kind of problems we call as polygenic inheritance. Understood? But නෑ එහෙම කියන්නේ නැහැ උනාට අපි ඒකට ඒ කියන්නේ පොලිජෙනික් තමයි ක්‍රොමෝසෝමල් ඩිසෝඩර් එක. එහෙම කියන්නේ නැහැ. Oh. Did you guys understand?
Yes, so what we're saying is, so Down syndrome is polygenic inheritance, is that it?
Down syndrome is like polygenic because many genes are involved, but you can't just simply say that it is polygenic. There is a separate definition for polygenicity. It's a bit complex, but for now, just understand that in chromosomal disorders, many genes are problematic. Either there are too many genes or there are too less genes. In conditions where one gene is problematic, those are called things like hemophilia, things like Marfan's. Only one small gene is involved. A small segment of the chromosome is problematic. Understood?
Yeah, I understood what he said.
Noonan syndrome is a problem in chromosome 15 and it is a autosomal dominant inheritance. Right?
So in chromosome 50, only one gene is affected there.
Yeah, not the whole chromosome.
Okay.
Whereas in Klinefelter and other, there is like whole chromosome is affected. So
yeah, understood.
Okay.
Yeah.
Okay. See you guys tomorrow.
Thank you.
Thank you.
Thank you.
Okay, bye.
Good night.